Hi, good evening. Thank you all for joining. First of all, I have no declarations. I don't own any Artelon chairs, but I wish I did, and so does Dr. Gan. Hint, hint. But
Yeah.
All right.
but I will tell you a bit of the history of why we started using Artelon, even though we had no idea what it was until a rep actually visited us in KL to show us this fiber. So let's start the presentation. It's not very long, it's about 10 minutes, and it's just a matter of showing you what we have done with the Artelon in Malaysia over the last 11 months. So my name is Dr. Aaron. I work in Island Hospital in Penang. Right, now let's get this. Okay, so why are we so interested in Artelon? We've been looking, we as in Dr. Gan and I, we work together quite a lot. We've been looking for a ligament, a biodegradable ligament, for the last 5-10 years. We know about LAS. I'm sure everybody knows LAS, which is still used at the moment. Dacron, Gore-Tex, and Kennedy in the early 80s, total disaster. So there obviously has to be a dissolvable ligament that you can use. And basically, it was actually just to augment our ACL reconstructions. That was the key, because the holdback with ACL reconstructions is actually the rehab. You can put in a nice graft, but you cannot make the patient or push the patient too fast because healing is slow. And it's exactly what Aaron Smith has said. At 6 to 12 weeks, that's when you actually get the patient, when a patient feels better, you actually get them walking more, you want to start exercise, but you cannot because you're afraid that the ligament will loosen up. And that's the main key. So biodegradable, why Artelon? Well, there were several things that actually struck me and struck us when we saw the ligament presented to us in KL. First, it's degradable. It's 5 years. You can start early rehab. Both of us, Dr. Gan and I, run our own rehabs. We have our own rehab departments for our athletes, for our own patients. So we monitor them very closely. We can be seeing them every 2-3 days because they're in the rehab department. We can be seeing them every week. So we see our patients very, very often. It is high strength, so you don't have to worry about it breaking very easily. In addition, because it's elastic, it actually creates tension on the ACL, so it tightens up your ACL. It also shortens the distance between your tunnels so that your ACL basically is at the shortest distance towards each other. On top of that, it's off the shelf. You just buy, you put it in the you put it in your OT. When you need it, you use. When you don't need it, you just leave it by the side. No refrigeration. So I mean, it has all the advantages that we are actually looking for. So Aaron Smith has gone through, so I won't go through the matrix again, but this is what it looks like at the top here. It comes like a tape, but if you look at it closely, it's actually fibrils, it's all woven, and there's actually a patch as well. And this is the integration at 2 years, which is actually shown you as well. So I won't go through this again. So it was actually shown to us in June 2019. We did a trial case in, I think around June, July, and we really liked it. So our local representative, Jeff, has actually managed to get the Artelon for us, and we started using it in earnest in November 2019. And so this is what I've done so far. Dr. Gan has his own figures. Basically, ACL, and this is a hybrid ACL. That means it's hamstrings and Artelon. ACL revisions, again, hamstrings and Artelon. Anterior cruciate ligament and ALL, which I will show you. PCL, we've done 2. Posterior lateral complex as well, and MPFL. And then I've used a patch in the massive rotator cuff tears as well. Now, there are other things you probably can use it for, which we haven't got around to doing. ATFL, deltoid reconstruction, TA reconstruction, elbow, the ulnar collateral ligament, and then for the hand surgeons, basically the DRUJ, TFCC reconstructions as well. Now, Artelon size, which we've been using, is a 7x32 because that's the biggest for the knee. I actually asked for a bigger size, but we were told that the manufacturing process is actually a bit difficult. The reason I wanted a bigger graft, which is slightly thicker, which basically will make your graft diameter more than 8 millimeters or 9 millimeters in diameter. So if you use hamstrings, semi-T, and gracilis, or if you triple the hamstrings and without gracilis, and you use a what do you call Artelon with it, I can guarantee you will get at least 8. We have never, even in the smallest ladies, I have never had any graft which is less than 8 millimeters in diameter if you add in Artelon. With a big patient, with athletes and who are very big, sometimes we've actually even managed to go up to 12. So remember to stretch it before. This is the piece, so you pull on it end to end, and this is the original size, so you can actually stretch it by 1 and 1.5 times, and it really does stretch. The trick to this is that if you're going to use the AL, you can actually cut off 10 cm here, use this part for the ACL, and use this part for the anterolateral ligament. So use one piece. So remember to put the Artelon on the endo button first. It has to be wrapped up by tendon. In other words, the tendon goes on top, the Artelon goes right on the middle, in the middle of the graft. So this is the Artelon in, and then after that the hamstrings on top. And then what you will see inside is like this. So this is an 8 millimeter graft. You can see the Artelon is here, hamstrings on both sides. So this is a small graft, 8 mm. This is a 11. Basically, you will not see the Artelon. Everything is covered up. Try and preserve the synovium and the stump if you can, and everything is covered up. You will not see the Artelon in the middle. And this is the Artelon, 8 millimeters. Here, 8 millimeter graft. And you can see it actually fills up the notch really nicely. I mean, this looks like a normal ACL. Okay, and that's where the stump goes down to, right to the bottom into the tibial tunnel. So remember, even at the bottom of when it exits the tunnel, onto the tibia, these are the hamstrings. This is the normal length of the Artelon. You have to pull on it first, because once you pull on it, you can see that the tibia, and you fix it, the tibia will move forward, and it stretches the tibia forward, so it maintains your relationship between the ACL and the PCL. It's actually very nice. And these are some pictures of the Artelon in ACL reconstruction. These are MRIs which were done post-op, and some at 6 months. So again, the Artelon is in the middle. That's the white part, and the hamstrings are in either side. Okay, and this is the same thing. Artelon in the middle, hamstrings on either side. This is a PCL we did. This is PCL. So this is a tibial. This is TA, tendo-Achilles allograft, and a single strand of Artelon from the tibia. From the femur going down to the tibia, and that is the Artelon on one side. Probably don't see it very well, but the black actually is the hamstrings. So this patient had ACL, PCL, lateral PLC, and also a medial collateral ligament, 4 ligament reconstruction. And this is for a PCL. You can see as you pull on the Artelon, the tibia actually comes forward. Right. So you fix it in tension. Don't forget to fix the Artelon in tension. So pull on it before you, and that's the tendo-Achilles allograft. And this is the video of the ACL PCL that we did for this same patient. So let's play this one again. So this is PCL, this is ACL. So you look at the PCL going up. That's part of it. That's the tendo-Achilles allograft, and there will be one piece of Artelon beside it, which doesn't come out of the MRI so well. So anterolateral ligament, same thing. You can do it percutaneous now. Drill lateral side, drill hole, reamer, pass the Artelon through, pass it under the soft tissues, go through the front, and you end up with 2 small incisions rather than a big incision. So anterolateral ligament. And this is a patient who had an MPFL. I didn't take any clinical pictures, but this is the Artelon going through the tibia. And this is the, then fixed on the middle side of the middle epicondyle, where the Artelon, so basically you drill through the tibia with Artelon, and 2 strands goes in through the middle side of the tibia onto the lateral side, and you fix it with 1 screw. So that saves you taking the hamstrings. And the other thing I like about this is that it's elastic. So don't over tension. If you don't over tension, when you bend the knee, it gives a bit just like a normal MPFL. I find with the semi-T or the gracilis, it's a bit too short. And sometimes it's too tight. And I've had 1 or 2 patients where it's really tight and it's full flexion. A bit too tight. Now, we just did this today. This is an Artelon patch. So remember, the patch comes in this size. So if it's cut for a rotator cuff to this size, is measured first. You actually try and repair the rotator cuff as much as possible from side to side. And whatever is left is a gap. And that gap is then filled up with Artelon down here. So this is actually used like a superior capsular reconstruction. I tend to put it as far in as possible over the top of the tendon, right as near to the glenoid as possible. Stitch it in place so that it becomes a detensioning device for your repair. So it's fixed at the top all the way down the sides on both sides, and then the bottom part is actually fixed to the humeral the greater tuberosity, so that you can actually detension the repair that you have. Again, same thing. So the possibilities are numerous. You can actually use it in any ligament reconstruction in the body. And I think we've been using it for the last year, and I'm very pleased with the results so far. And Dr. Gan will show you some of the results that he has. Thank you very much.